asymmetry, and if there is restriction, and we also assess the conductance of the air from inside through asking the patient to do certain maneuvers. Okay, sir, do you have any pain in your chest?
No.
There's no pain there. So I'm looking there for areas of tenderness, crevitus or nodules, and I can't see any. Now, in terms of assessment of movement, we use a technique to assess that, which includes putting the hands on the patient's chest, and I'm using the lower part, which is the lower part of the chest. You need to mold your hand to the chest wall without being strong in the grip, rather loose, and asking your patient to take a deep breath in and see the movement. Can you take a deep breath in, sir? Big one, and out, and out. Through your mouth, okay, and out, and again. So you can see clearly there is movement, which is symmetrical. The amount of movement gives you an idea about restriction. Normally should be more than 5 centimeters. Okay, sir, again, in the area of the midline, take a deep breath through your mouth, and out, and again, and out. Now, in the apical side, again, big breath through your mouth, and out, and again. So that gives us an idea about symmetry and extent of movement. The next step would be, apart from the assessment of the movement and symmetry of movement, palpating for tenderness and swelling, or crevitus, is to assess for the conductance of sounds. So you can ask your patient, if he's an Arabic speaker, to say 44, English speaker to say 99, or you can ask them to say 111. So can you say 99? 99? Say 99?
99.
Say 99?
Say 99.
99?
99.
So with that, you can do comparison at the same time, or you can take it one by one, which is 99,
99.
99,
99.
99,
99.
and again,
99.
and again,
99.
again.
99.
That's fine. So with this one, the tactile vocal fremitus gives you a feel of the difference between the two in terms of conductance of this sound. It gets better conducted if there's an area of consolidation or segmental atelectasis or on top of pleural effusion. It comes reduced in patients with emphysema, collapse, or on the pleural effusion or a pneumothorax itself. It may be absent if there is a significant pneumothorax or pleural fluid collection. So this is an important sign to do, although it's not a very hard sign. It's very relative to in terms of interpretation. Now, palpation should also include assessing for the epic speed, which has been discussed in the cardiology assessment, and feeling for the second harsh sound to see if it's palpable, as a palpable second harsh sound indicate presence of pulmonary hypertension. Now, after palpating the chest, our next step will be auscultation. So basically, after palpation, our next step will be percussion. Now, in percussion, you need to get yourself used to the technique. It takes time, but with practice it gets better. We always separate the fingers on the left hand. We percuss on the middle finger, in the middle phalange, with the right side. So I'm just going to show you as a demonstration here of how it's done. Now, as a pattern of doing the test, we'd always inform our patient that we're going to be doing this percussion in case the patient may feel some pain. And percussing the chest include percussion from the apices, and then we go on the pattern from one side to the other side. If on examination we find one side moves less, where we could assume this is the diseased side, where the pathology is, we should start from the normal side. In this patient in particular, both sides were moving equally normal. So what I will do percussion. Sir, can you look to the right side? Percuss on the apex on the right side, and then on the other side, on the clavicle, on the left side, and then remember, you will have cardiac dullness here due to the presence of the heart. Now, on the anterior side, your resonance pattern may change in the presence of the liver, and here we do what we call tidal percussion. Sir, can you take a deep breath in and hold? Big, 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 and hold. And breathe out. So we look for the change in the percussion note. The typical percussion note will be resonant due to the presence of air in the lung. In areas where there are other structures like the heart or the liver, we have dullness. We do have other descriptions of hyperresonance if there's increased amount of air like what we see with pneumothorax, or stony dullness like what we see in pleural effusion. Our next examination will be auscultating the patient. The objective of auscultation is to identify the presence of passage of air, to recognize what type of breathing it is, and to assess for the presence of added sounds. A normal breath sounds will be vesicular. Sometimes we find bronchovesicular when we examine centrally, and bronchial breathing is pathological if it's found in the periphery of the lung. We usually use the diaphragm to listen to the breath sounds, although sometimes you can use the bell. Now, I would ask my patient to take a deep breath in and out with their mouth open so that they understand it. A common mistake would be not being able to hear the sounds or not to recognize normal or abnormal sounds due to poor effort. My objectives will be to listen to the presence of air passage, breath sounds type, and presence of added sounds. The common added sounds you're expected to know about are crackles, or we also call crepitations, rhonchi, which can also be called wheeze, presence of pleural rub, and other added sounds. Okay, sir? I would like you to take a deep breath in and out. So, breathe in with your mouth open, and out, and again, sir. Okay. Now, breathe again, and out, and 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 again, and out. Now, with that, you will be able to recognize, one, if air is passing normally through the lung fields, what type of breath sound it is, and each one has its particular association with pathologies. Two, you'd also find if there are any added sounds and if they have significance in the clinical assessment of patients. Those will be described in one of the slides, what causes different types of breath sounds. Now, we sometimes, if you find an abnormality, ask our patient to cough and listen back to the breath sound, particularly when you hear crackles. This is one of the areas you need to do a post-TOSEF test. A common position to examine our patient would be a patient sitting up. This is common in clinics and in exam scenarios. The same steps of examination will be followed up in examining our patient from the back. Make sure the patient is comfortable, the patient is not distressed, and try to make sure that they have perfect light for examination and better exposure. One of the ways to deal with this is to ask your patient to cross their arms. Sir, can I ask you to put your right on the left like this and this one on the other side? Now, if the patient is not comfortable to keep it for long, you could put a tray or a table in front of the patient with a pillow to help them. That will be fine. Okay? So I will be doing the same by asking the patient to take a deep breath in and out. Can I take a breath? And out. So again, I'll be looking for symmetry of movement, if there is any intercostal or subcostal recessions, and I would inspect the patient for the presence of scars, distended veins, deformities, looking at the sides also, and if there is any pigmented lesions or mass lesions. That will also be followed up by palpation. Do you have pain? Any pain? No. By making sure there is no pain, there is no tenderness there, and there are no nodules. I would follow this up by looking at the chest expansion. As we said early on, you look for symmetry of movement and extent of movement. Let me try with this one. Okay, sir, like before, through your mouth, I want to take a deep breath in and out. And out. And again. Very good. Thank you, sir. That's fine. Breathe normally now, sir. Again. And out. And again. That's very good. And the last one. And again. So we look at 3 areas, top, median, and lower, to assess, because you may have selective restriction. We assess the symmetry of movement, and as we said, the side which moves less is the diseased side likely. Now, our examination with palpation is not complete without doing tactile focal perimeters. As we did before, we could ask our patient to say 99? 99? 99? 99? 99? 99? 99? We can also say 111, or we can use 44 if he's an Arabic speaking. That gives us an idea about if there is any reduction in or selective difference, and there are differential possibilities for those. Now, that would be followed up by doing our percussion. I have done the percussion on the apex, but you can do it from the back. Can you see across your arms like this, like I did ask you? Very good. And just leave it like this. Now, percussing on the muscles give you what we call dull note. It's not typically what we call flat note. It's not typically dull or resonant. So avoid percussing on the muscles. And by asking the patient to do this, we remove the scapula from the way. So when you find dullness on the right side, remember the liver, and ask the patient to take a deep breath in, big breath in, and hold. And check with the tidal percussion if that's a liver or a pathological process in the lung. Now, after percussion, we do auscultation. And again, with the same steps, we'll ask our patient to take a deep breath in and out. Big breath. And out. And again. And out. And again. And out. And again. And out. And again. And out. And again, and again, and out, and again, and out. Now, here we're going to show you how to do tactile vocal resonance with same like tactile vocal perimeters. Can you say 99? 99. And again? 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 99. Now, in certain conditions, you may need to do more maneuvers. As we said, if you find presence of crackles, you ask your patient to cough, what we call post-tossive test. If you suspect presence of cavitating lesion or extensive consolidation, we'll ask our patient to look for egophony and bronchophony to do certain maneuvers like saying A, and we can also detect presence of unforced breathing by listening to the patient's chest. Now, with that, you would have examination of the chest proper, but as we know, other systems may be involved in respiratory examination. So if there was evidence of right heart failure or congestive heart failure, I'll feel the patient for presence of sacral edema. Now, I'm going to put my patient back into his position. Sir, can you lie back there? Now, we need to do examination of other systems, so your respiratory system examination is not complete without making sure that you check the JVB of the patient, that there is no increase in the central venous pressure as it's assessed. Examination of the abdomen for presence of enlargement of the liver, hepatomegaly, or pulsatile tender liver may be seen in patients with tricuspid regurg secondary to pulmonary hypertension. And examining our patient for presence of lower limb edema as an important component of features of cor pulmonale. During this examination, I gave you the step approach to an assessment of a patient. Our patient may not have all the signs and symptoms, so I would always recommend that to think what are the likelihood of signs to be present in a particular patient. As we earlier said on, somebody was clubbing, you have to consider the common cause of clubbing and look for specific signs. If a patient has a face suggestive of lupus, then on examination you need to confirm the presence or absence of lupus and the presence of pulmonary complications. After examining our patients, we are obliged to express or to pass our findings in a very descriptive way, either by describing our important positives and negatives, knowing what we're looking for, or what we call giving a summary. So in a typical patient with asthma, we would say the patient has no clubbing, air febrile, in distress, intercostal recessions, active LNSI. Examination of the chest shows bilateral reduced air entry with expiratory wheeze. The likelihood is asthma. This is one way to deal with it. Or you can say your patient likely has right-sided pleural effusion. You can suggest what's the likely cause of this. For example, infection or non-infection, and you comment on the presence or absence of respiratory failure. With that, I will conclude, and I would suggest for my students to refer to the textbook in clinical examination and to try to read about the association of certain signs with certain clinical conditions. Thank you very much.